usually takes a moment or two for it to open for the attendees. So I see that some people are starting to arrive. So I would like to start by saying good afternoon and welcoming everyone in our audience, as well as our guest speaker for today, Dr. Stearns. Dr. Stearns is the director of the Women's Malignancies Disease Group and professor of oncology at the Johns Hopkins School of Medicine. Today, she will provide medical oncology research updates for advances in the treatment of metastatic breast cancer. So Dr. Stearns, I'd like to take this opportunity to welcome you, and I open the floor for your presentation.
Thank you so much, Gillian, for inviting me back, and for our audience for joining. I spoke just over a year ago, and what I tried to do is take some of the same elements that we talked about last year and then add some of the advances. Many have been reported just about a month ago. So thank you so much for joining, and I'll share my screen now. If there are any issues, please let me know. Great. So just a reminder, I like to start with an overview. Breast cancer continues to be the most common cancer diagnosed in women. About 12% of all new breast cancer worldwide, and about a quarter of all cancers in women are breast cancers. It is the 5th most common cause of cancer-related death in women, but second in the US. Key is that the majority of breast cancer are hormone receptor positive, and it's important to remember that because the majority of women living with breast cancer will have hormone responsive disease, but triple negative breast cancers and Enhertu positive breast cancer are the other 2 major subtypes that I will talk about today. Women are mostly diagnosed in Western societies with early stage disease, and many will be able to survive their cancer, but others will have a recurrence, and some women may be diagnosed initially with a metastatic breast cancer, and we're not always sure what some of the factors and triggers are. Once metastatic, breast cancer today is mostly not one that we can cure, but women can live with it for many years or decades. And because of that, it's important for women to seek state-of-the-art care, clinical trials, and other wellness approaches to live well with their cancer. So what is metastatic breast cancer? So we know that a cancer initially originates within breast tissue, mostly in the ducts, sometimes in the lobules, and rarely in other parts of the breast tissue. If it's spread to lymph nodes in the underarm area or the axilla or above or under the clavicle, it's still a breast cancer. It can be managed and potentially cured. But if cancer cells spread into lung, liver, bone, or brain, those are the situations when we refer to the breast cancer as metastatic. What are our goals? Ideally, we would like to cure the cancer. We would like to make it go away and never come back. It's not something that we achieve often, but we can sometimes, and therefore it's important for every individual to talk about the goals of care with their team. We do know that treatments today help people live longer with their cancer, and some treatments can help delay the cancer from progressing. And I put in parentheses some of the terms that I'll be sharing with you later. Prolonging life is overall survival, and delaying cancer progression is progression-free survival. We know that our treatments help reduce symptoms from the cancer, and we also look to minimize risk of complication from cancer depending on where it grows. At the same time, we want to reduce or minimize toxicity from the treatments, and we want to ensure that people have the longest possible time with quality. I referred a little bit to molecular subtypes, and this continues to evolve, but the majority of hormone receptor positive breast cancer are luminal A or B. And interestingly, we do see that the subtypes differs in breast cancer that presents itself early or primary versus metastatic. So luminal A is breast cancer that has high expression of estrogen progesterone receptors and a low growth rate. And we know that many of those cancer probably are treated successfully in the early stages with hormonal therapies. Other cancer that are called normal-like, again, there's a higher proportion in early breast cancer compared to more metastatic. So when we look at the metastatic distribution, they're more luminal B, and those are cancers that have the estrogen receptor on them, but tend to be a little bit more hormone resistance, and chemotherapy and other treatments may be required. And there's more HER2-enriched tumors, and basal-like, most of those will be what we call today triple-negative breast cancer. And what are the treatment options? This is a summary, and I was very happy I was able to add this entire column here today. Hormone receptor positive is cancer that can be treated with treatments that target the hormone receptors to reduce the amount of estrogen that's seen by the cells. Many are now in combination with novel drugs. Chemotherapy is very effective as well. And again, I'm focusing here on metastatic breast cancer. HER2 positive cancer can be treated by anti-HER2 agents, often with chemotherapy, sometimes with hormone therapy. And triple negative breast cancer is treated mostly with chemotherapy, but we do have immunotherapy available for people who have PD-L1 positive disease today. And there's some emerging novel agents. People with cancer has related to the BRCA deletion, people who are carriers for the BRCA gene can be treated today with PARP inhibitors. And then this is very, very new, and I'll talk today about what does HER2 low mean. Of course, at every time you're considering a new treatment, I would look into potential of clinical trials. So how do I think about the treatment approaches when I talk to an individual with metastatic breast cancer? If the cancer have hormone receptors, I usually try to start with some combination of hormonal therapy. I would say that today we don't use tamoxifen or aromatase inhibitors by themselves very often. In women who are premenopausal at the time of diagnosis, we would usually also consider suppressing their ovaries in order to consider aromatase inhibitor or fulvestrant. But we tend to combine those endocrine therapies with either cyclin-dependent kinase inhibitor or CDK inhibitors, and there's 3 here. There's a drug called everolimus, which inhibits the mTOR pathway, and then a drug approved a couple of years ago called alpelisib that inhibits the PIK3CA pathway. The most common first-line treatment in people who have hormone receptor positive metastatic breast cancer is a combination of one of those 3 CDK inhibitors, either palbociclib, ribociclib, or abemaciclib, and that's usually given with either an aromatase inhibitor or fulvestrant. CDK inhibitors are tolerated reasonably well. Women may be on those medications for several years, so it's important for us to try and minimize side effects by reducing the drug dose or creating drug holidays. But we do see low white cell counts occasionally, and there could be low red blood cell counts or low platelets. And many women complain of fatigue or weakness. There could be mouth sores or hair thinning. There could be gastrointestinal symptoms. Diarrhea is common with the abemaciclib. And then there could be what we call neuropathy or sensation of numbness or tingling in the hands or feet. We rarely see pneumonitis, but we do ask women about respiratory symptoms. And again, we wanted to try and highlight some new study results. And just last year, data presented from a study called Emerald, in which women who had a metastatic estrogen receptor, estrogen receptor positive breast cancer that was HER2 negative were randomized to either one of the common medication, fulvestrant, anastrozole, letrozole, exemestane, with what we call an oral SERD, which is a selective modulator of the estrogen receptor, and it's called Elacestrant. And the study investigator looked at the number of women whose cancer has progressed and the duration of time to the progression. And what they've seen, and I'll walk you through this as I'm going to show you several of these figures that we call Kaplan-Meier figures. So what you see is on the x-axis is time in months, and then on the y, we see the probability of the progression of the cancer in this one. And in the dark green, the curve is indicating the people who were on the study drug, the Elacestrant, and on the lighter blue color, women who were on the Fulvestrant, which would have been considered the standard. And what you see that initially, basically every line is an individual whose cancer has progressed. So we do know that when we do our first scan, usually 2 to 3 months after starting a drug, there's some people who just never responded. So that's that drop that you see here. And then over time, whenever there's a symptom of blood test change or a change in a scan, every time there's a person whose cancer progressed, this is captured on the curve. So what you can see is the people who were on the study medication, the Elacestrant, where it has taken them longer to stop the medication compared to those on Fulvestrant. So that tells us that this medication is working more effectively in people with this tumor type. Now, another term that you may have heard about that we've been discussing more and more is a mutation in the estrogen receptor. ESR1 is the estrogen receptor. And we know that people who've been on an aromatase inhibitor in particular for some time, months or years, start developing this mutation. And this mutation may make their cancer more resistant to our treatments. And what this study showed that even people who had the mutation had a lot of benefit from this medication, more so than Fulvestrant. So I do anticipate that this drug will be approved in coming months for use in our clinics. So when I think of managing this tumor type, I would say that most women will initially probably fall into this paradigm here in the middle, an aromatase inhibitor with a CDK inhibitor, and if there's progression, will receive Fulvestrant. If they have a PIK3CA mutation, they will have alpelisib, and then they can move on to everolimus or chemotherapy or other novel therapy. So that's some of the things I think about is whether the cancer has recurred, where it is in the body, what symptoms, what other illnesses a person might have. As I said previously, clinical trials are something to think about every step. Now I wanted to talk a little bit about targeting HER2. So about 15 to 20% of breast cancer are HER2 positive. The HER2 is basically a receptor that sits on the cells, and in some cancer, there's many copies of these, and because of these many copies, we can target, block them with some of our medications. Some are listed here, for example, Trastuzumab, Pertuzumab. And what do we call HER2 positive? Today, if the cancer cells are stained by immunohistochemistry assay, and the pathologist called this a 3+ result, or if we do what's called a FISH assay and there are more than 2 copies, that's what's considered today HER2 positive. And we know that people who have these tumor types and receive anti-HER2 treatments can live for many years, sometimes with these medications. And there have been many more medications that were developed and approved in recent years. So one example is Tucatinib, which is a medication taken as a pill, with Trastuzumab, which is a Herceptin, and Capecitabine, which is Lichota in HER2 positive metastatic breast cancer. And again, we're looking at those Kaplan-Meier curves, and as you can see, the people in the blue line here are the people who received this combination with Tucatinib. And these people were able to live with their cancer longer before there has been a progression compared to people who were not receiving the Tucatinib. And this graph shows us that people were also living longer if they were on this combination. So this was approved about 2 years ago by the FDA, and it's used commonly in our clinic. Another medication that's being used quite often in recent years is Trastuzumab deruxtecan, and it's also called Enhertu, and that's initially shown that people who have received many types of prior treatments are now able to receive Enhertu and have quite a bit of benefit. And this is an injection, an infusion that's given every three weeks. So we have several treatment options for people with metastatic HER2-positive breast cancer. And this is roughly in the order that I would consider it for an individual. So at a new diagnosis, I may give docetaxel or paclitaxel with trastuzumab, which is Herceptin, and pertuzumab, which is Perjeta. And then I would consider Enhertu or TDM1. And then there are several other, as Tucatinib, neratinib. So the longer a person is on one medication or combination, then the more options are likely to be available to her. I want to talk a little bit about chemotherapy for metastatic breast cancer. And I think you may have seen that I had a little question here about the use of Enhertu and HER2 low, and I'll talk about that in just a moment. So when do we consider chemotherapy in metastatic breast cancer? So in most women who have hormone receptor-positive breast cancer, I say most, but not all, I will start with hormonal treatment combinations. And then if after 2 or 3 different combination or treatment, the cancer continues to grow, as I would consider chemotherapy. There are some situations that I would consider chemotherapy before hormonal therapy, but those are less common. If the cancer is HER2 positive, I would add anti-HER2 medications usually to the, I would add chemotherapy to the anti-HER2 medication. And then in triple negative breast cancer, we still don't know very well how to think of this subtype as more as a group of different types of cancer with complex biology. So today we really are providing mostly chemotherapy. We do know that women who have the PD-L1 antibody might benefit from immunotherapy, and I'll talk about it in just a minute. But there really isn't what I would call a standard novel non-chemotherapy agent for triple negative breast cancer. How do I think about the chemotherapy used in metastatic breast cancer? We look at what treatment a person may have received before, whether there are other illnesses. Sometimes we know that individuals may have had a toxicity to one treatment, and we want to avoid another treatment that could cause the same toxicity. We will also think about the patient preference. Some medications are given via pills, but not the majority are infusions, and some can be once a week or every other week, and some could be once a month. We don't always have a choice, but if there's more than one potential regimen, I very much like to know the patient preference. For the most part, we give one chemotherapy agent, and if it stops working, think of another one. But there are some situations we give more than one agent alone. And there really isn't one optimal sequence. I would say that a lot of time we will start with something like paclitaxel, but sometimes we'll start with something like Capecitabine or Lichota because it's a pill form and it's a lot easier on people. One medication that I talked about last year is Trastuzumab, which was approved just over 2 years ago for metastatic breast cancer. And importantly, it is chemotherapy. It improves survival, meaning people who received this in the study live longer than people that got other chemotherapies. So it is something that we are thinking about early on for patients who have metastatic triple-negative breast cancer. It does have quite a few gastrointestinal side effects and neutropenia and anemia. So we quite often have to reduce the dose or give it every other week. Another recent update, so I just told you that Trastuzumab is approved for triple-negative breast cancer, but in our national meeting last month, results from the study called Tropics 2 were presented in people who have hormone receptor-positive breast cancer. And in these studies, the women received either Trastuzumab or a physician choice chemotherapy, and those are the potential agents that were received. And what did the investigators report? They reported that women who received the Trastuzumab in the green line here were less likely to have their cancer progress compared to the other chemotherapies at all the time points that they've looked at. So this is something that could become available to women with hormone receptor-positive breast cancers as well. This is probably the study that made the headlines more than any other studies and have demonstrated very, very significant benefit. And this is called Destiny Breast 04 studies. And here, the drug I just mentioned to you that's being used for HER2-positive breast cancer called Trastuzumab deruxtecan, or TDX, was compared to treatment of physician choice in patients with what is now called HER2-low metastatic breast cancer. So what is HER2-low? I told you the 3+ using immunohistochemistry is positive. The HER2-low, according to the study, was a 1+ or 2+ by pathologist ratings, meaning that they've seen some extra copies of the HER2 gene. In the studies, those patients with this, as I told you, immunohistochemistry 1+ or 2+, either received the Enhertu or physician choice chemotherapy. And what we've seen is when you look at this progression-free survival or cancer progressing on treatment, those on the Enhertu or arms were less likely to have their cancer grow at different time points compared to women who receive other types of chemotherapy. But importantly, there was a very, very significant improvement in the time living with their cancer shown here. This is the overall survival. So women were living longer by an average of 6 months, which is very significant. It's actually reasonably well tolerated. The medication may cause nausea or neutropenia. There is a rare side effects of pneumonitis. It's something that we ask people about quite often. And there could be a small risk of weakening the heart muscle, and we do cardiograms for these individuals over time. I wanted to shift gears and talk for a moment about immunotherapy. So immunotherapy is a type of approach that has been very, very beneficial to some tumor types, such as melanoma or lung cancer or lymphoma, cancers that we think are what we call immunogenic. In breast cancer, we have not seen the same substantial benefits, but we've seen some initial responses to immunotherapy-based treatment. Basically, what we're trying to do is put the brakes on the immune system from letting the cancer grow and spread. And we have learned from other tumor types that adding chemotherapy to immunotherapy could be beneficial. So in this study, women with triple-negative breast cancer received pembrolizumab, which is a drug that targets a receptor on immune cells and cancer cells called PD-L1, with chemotherapy or just chemotherapy alone. And what we've seen is that women who have who were receiving the pembrolizumab in addition to chemotherapy had slower growth and progression of their cancer, seen here in the green line in all the patients treated. The investigators then looked at the number of cells that have the PDL on the cells, and have seen that if you have a low amount, you have more benefit than on chemotherapy alone. But then if you have a higher value of this score, it's a composite score, then you're more likely to benefit from the addition of immunotherapy to chemotherapy. This was also seen in terms of overall survival benefits. So people who receive pembrolizumab in addition to chemotherapy and have this higher score of this composite, the combined positive score, were able to live longer by a few months compared to people who got chemotherapy alone. So right now, we do recommend pembrolizumab and chemotherapy. It could be either a taxane or a platinum-based regimen with pembrolizumab if they have the PD-L1 score on their cells. So it's something that's very important to determine very quickly if the cancer has returned. We do have other treatments and interventions that I did not want to go over with detail today, but happy to answer questions. So if a person has the BRCA gene deficits, a person who has a mutation in BRCA, that person can receive PARP inhibitors today, which are medications that are given as pills. So we very much want people to have a genetic test if they're diagnosed with cancer, in particular metastatic cancer. We also now test the tumor cells for what we call genomics. We know that in addition to the genes that we're born with that could harbor mutations, the cancer cells collect new mutations over time. So for example, cancer cells can have a HER2 mutation, even though they're HER2 negative, but then they can receive the anti-HER2 therapies. Tumor mutation burden is another thing. This just tells you basically the number of mutations may be presented in the cell. And if there's a large number, those women can receive immunotherapy. And there are many, many other smaller groups of genes that can be targeted. Sometimes we'll borrow a medication from a different tumor type if a person has a specific mutation. We do know that some triple-negative breast cancer have the androgen receptor, that's the male hormone receptor on them, and they can be receiving some medications that have been commonly used in prostate cancer. And the antibody drug conjugate are, for example, the Enhertu that I talked to you about, that seems to be quite promising. In metastatic breast cancer, we try to give treatments that go throughout the body, but at times, we would consider surgery, radiation, or other intervention. For example, freezing or trying to administer high dose of intervention and radiation to an organ if that causes a symptom, if it presses on something, or if there's pain. Radiation is quite commonly given to bone. Another situation that's challenging is brain metastasis, and I'm not talking about this specifically today, but as a reminder that we do have a barrier that's called blood-brain barrier, and the goal of this barrier is to keep things that are toxic from our brain. And unfortunately, at times, cancer cells do find a way through this barrier, and we could see metastatic sites within the brain or the fluid surrounding the spinal cord. And those are a little bit challenging because our treatments are not always very good at crossing these barriers. We think that some of the pills, like the hormonal therapies, some of the anti-HER2 therapy could be effective in the brain as well. But it's something that needs to be looked at a little bit differently. people who will have cancer metastasis in bone, we would also recommend bone modifying agents too. It's just medications that have commonly been used for osteoporosis and are used to help strengthen the bone and hopefully prevent need for radiation or fractures or pain medications. And then there may be other medications that could help either given with the chemotherapy or other treatments, or to help reduce side effects of treatment. I wanted to just say a word about a new program that we've been developing that we call Hopkins. And a lot of the credit goes to my colleague, Dr. Karen Smith, who practices at Sibley Memorial Hospital, our navigator, Elizabeth Saylor, and our patient advocate, Christine Hodgson, and our program coordinator, Jackie Bacon. And we have several other physicians working with us, and we've been fortunate to receive some support for this. And our goal is to try and provide an individualized approach to the care of patients with metastatic breast cancer. I've told you about the many possible treatments and clinical trials, but we do know that once you're diagnosed with metastatic breast cancer, there's a lot for you to think about, and we want to try and provide additional assessments, care, and resources and education beyond just the day-to-day treatment. And while the resources are available to our patients, they don't always know about them. So we wanted to try and bring the information about treatments, but also wellness to the patients from the very beginning of the care of their cancer. So do ask any of our navigators or providers about the program and whether this is something that you could consider. So in summary, I believe that we've made significant progress in understanding and treating breast cancer, and many treatments are available to women with metastatic breast cancer. Our challenge is to understand how cancer evolves over time and how to best treat it every step of the way. We're still using scans and blood tests to try and give us clues whether the cancer is trying to grow and whether treatment change is needed, but hope that we'll have more sensitive tests in coming years. And ongoing and future trials will help us better tailor the treatments to individual patients, and hopefully by doing so, minimizing over and under treatment. And with that, I just wanted to thank you to my colleagues at the Women's Malignancies Disease Group at Hopkins. And I also wanted to give a special thank you to Gillian Lichota, who is the founder and chief executive officer of I Rise Above Breast Cancers. I believe that she has done what we all hope could be done with healthcare system, and is bringing the wellness and education approaches to women who will be stronger in fighting their cancer. And with that, I'm going to end and see what questions might come up.
Thank you for that. That was very informative. Do we have any questions from our audience on the presentation from today? Nobody? I do. I have a couple questions.
Sure.
So I guess I'll start. I was just writing down questions when you were speaking. So I also live with metastatic breast cancer, and I've been fortunate thus far for my disease not to have progressed yet. But should it progress, what is the process that would be, or sort of the protocol for finding out if the actual breast cancer has mutated? Is that something that my oncologist would, do some genetic testing to find out if, or is it something I ask for? What is the protocol for that?
Yeah, so that's a very good question, and I would say that the answer today might be a little bit different than what an answer might be in 3 months or 6 months or 12 months from now. But today, if I see a woman whose cancer I worry might be progressing, and then if we confirm that the cancer is grown on the current treatment by a scan or a symptom or blood test, then I would try to make the best informed recommendation for the next treatment. And the factors I would look at, one is the subtype of the cancer. So we talked about having hormone receptors or HER2 receptors or having a triple negative cancer. Today, I would want to make sure that she had a genetic test, meaning that I know whether she's a BRCA carrier or not. And by the way, there'll be other genes we're going to be looking for in coming years. And then I might want to do a biopsy if there's something that I can biopsy, let's say a liver lesion or a lung lesion, because we know, and I've shown you that sometimes the cancer that has grown and come back may be different than her initial cancer. And we can do a sophisticated genetic test of that tumor cell. And again, it's something that we have many tests for today, and I anticipated tests are going to get even more sophisticated. So I try to do the test in the most proximal time to when a treatment change is anticipated. There's also many clinical trials that as part of the trial, there may be a need for a biopsy. Sometimes we're not able to do a biopsy, and we do what's called liquid biopsy, which is getting a blood sample for this assessment for the genetic mutation. The problem with the blood test, it's not as comprehensive. It's what we've seen in the tissue. It's pretty close though. At the same time, there's some question whether the blood test could be better for some people than a biopsy, because if I do a biopsy, I do it of one area, whether it's one liver area, one lung area, and it's possible the blood test pulls more DNA from different sites. So it's something that continues to be evolving, and definitely something to ask your doctor about if and when there is a need to change treatment.
Okay, we have a couple of questions from our audience. I'll do the first one here. Is there any benefit in using Enhertu if you are not HER2 positive? And a follow-up to that is, will you transition patients who are on Ibrance letrozole to Elacestrant? I don't know if I'm saying that right. Once it is approved.
Sure. So, I'm going to start with the second question, if that's okay. So, I don't usually change treatment if it's been working. So, if someone has been on Ibrance, for example, and it's been working for her, then I would not change it today, because the benefits already been observed, and also because the studies were done in a little bit different way. So I cannot be 100% sure that the Elacestrant will necessarily benefit her. So it's something that I would reserve. I change treatment either if it's not working or if there's toxicity to it. And then since I've taken the second question first, I forgot the first one.
Is there a benefit in using Enhertu if you are not HER2 positive?
Yes, thank you. So those are the results that were presented in our main conference in June, and have shown that people have HER2 low breast cancer. So again, this is not HER2 3+ positive or FISH positive, but not HER2 0. So 1+ or 2+ have substantial benefit from Enhertu compared to chemotherapy. So if you have metastatic breast cancer that's not HER2 positive, it could be either estrogen receptor positive or negative, and the HER2 value was determined as 1+ or 2+ at any time, you may be eligible to receive Enhertu. It's already part of our guidelines. We anticipate approval by the FDA pretty soon, and many of our patients are already receiving this treatment.
Thank you. Another question is from Patricia. I have ER positive, HER2 negative metastatic breast cancer starting in bones and has progressed to her liver. Can you talk a little more about the bone modifying agents? And second part of that, she says, I get an injection of Xgeva every 3 months and is currently taking Verzenio with Fulvestrant injections.
Thank you. So yeah, so Xgeva is an example of a bone modifying agent. The most common ones are Xgeva that's given as an injection or Zometa that's given as an infusion. Those are the two common ones. There are a few others. And those are, so people who have metastatic breast cancer to bones, in addition to the treatment for the cancer, in this particular case, it was Verzenio and Fulvestrant, will also be receiving a medication that helps protect the bone and reduce the potential need for radiation, pain medication, or having a fracture. So that's the right treatment for the individual with bone metastasis.
Jennifer has a question. Is Elacestrant something to consider if one has already progressed on endocrine therapy and has already received chemotherapy?
Yeah, so that's definitely a question that comes up a lot. If somebody has already received several types of treatments and there's a new drug, but the new drug was tested in a slightly different scenario, is it something that should be tried? And it's definitely something that I would talk to your oncologist about and consider taking it. So for example, when we think of the CDK inhibitors that we talked about, like Ibrance or Kisqali or Verzenio, when they first became available, we've had many women who've never received those, who received already hormonal therapy and chemotherapy, and we were able to try and give them the medication, and they benefited from those for many months or even years. So I think it depends on the scenario, how many cancer metastatic sites there are, how the person is feeling, how many other treatments she's received. It's something that could be potentially considered.
Thank you. Are there more questions in the audience? Oh, there's a separate one. Okay. What is the average success with Trodelvy as a line of treatment?
Right. So Trodelvy is Acetuzumab, which I've talked about. So it has shown that compared to other chemotherapy types in triple negative breast cancer, it provides substantial additional benefits. So the cancer progresses more slowly and people can live longer with their cancer. So it's been very successful in terms of the benefit, but I do think that it has a little bit more toxicity than many other chemotherapies. So people have to be in touch regularly with their teams to let them know of potential symptoms so the medication can be adjusted.
Okay, Heather asks, for the drugs that list pneumonitis, sorry, as a serious side effect, is that more of a concern for those with lung mets?
Yeah, no, excellent question. If you have lung metastasis, sometimes you might have symptoms such as a cough or pain in the chest area or shortness of breath, which are similar symptoms to pneumonitis. So it's very challenging to know. We don't know is the answer, but we do know that if it's the right medication sequence, then it's definitely something that one should talk to their doctor about and have followed their symptoms quite closely. So if the symptoms get better, usually that means that the medication is working. If the symptoms are new or get worse, then there can be other tests to make sure this is not a pneumonitis.
Okay, next question is from Mary. Can we stay on bone strengthening meds like Zometa long term?
So when the initial studies of drugs like Zometa were done quite a few years ago, women were getting them just about every month. So they were getting monthly infusions or injections. And what we found after a while, because many women can live with their cancers, as we talked about for years or decades, that on the study, we've followed them for about 2 years, but in practice, we've been given these treatments for many years. The potential for something called osteonecrosis of the jaw, which is a side effect, which causes a destruction in the bone, which could be quite significant. The risk goes up when you're on it for quite some time. We have done studies since of giving the medications less often, for example, every 3 months, which is more common right now. And if a woman is on medication for some time and haven't had any issues with her bone metastases, it can be spread even further, but it can be given for many, many years.
Okay, the next question is from Heather. If I got this right. I don't see much discussion of QOL. Is there a subspecialty that looks at PFS versus side effects, not just toxicity, but QOL? I don't know what QOL is.
Yeah. So QOL is quality of life. And
okay.
Yeah, I spoke today mostly on the type of treatments and new treatments. I talked a little bit about side effects, but not for every one of the drugs. But most studies done today will have a quality of life component. So women will be asked to complete a diary or be interviewed for symptoms, and there'll be a comparison among the women who receive what would be the standard treatment versus what's being studied, whether it's a new drug or a combination. It's not something I focused on today, but it's definitely very, very important part of what we think about and talk to women about when we discuss the treatment options, and maybe a topic for a future webinar.
Patty asked the question, do you see much osteochronosis in patients that are on bone strengtheners?
Right, so as I just mentioned, women who have been on medications like Zometa or Xgeva for usually many years are at risk for osteonecrosis. It's not a common side effect, and since we've become more aware of it and we give the medications less often, it's even less frequent. We try to ask women to have a good dental exam before starting these medications, and if they do need to have a dental procedure while these medications, we're in communication with their dentist. But I would say that it's pretty uncommon today, but yes, it could still happen.
Okay, Patricia asked, I was briefly considered for the trial, and she forgets the name, and was tested for HER2 positive. She was first diagnosed as HER2 negative. It was at 0. Is it possible to see HER2 negative change to HER2 positive?
So the answer is yes. Not commonly, but 10 to 15% of cancers can change over time. And in particular, if many years have passed from the initial testing, it's worth considering another biopsy and a new test. So some cancers could have been HER2 negative and now be positive or borderline positive and open the door to more treatment options. Some cancers were estrogen receptor positive and become estrogen receptor negative. So I consider a biopsy either if there's a new treatment option or if something didn't quite fit, if I started a medication and it didn't work as I expected it to. So definitely discuss this with your doctor.
The next question is from an anonymous attendee. It says, if you haven't already, could you comment on the latest Paloma-2 findings?
Sure. So Paloma-2 was a study in which Ibrance was used in combination with an aromatase inhibitor, and the combination was compared to the aromatase inhibitor by itself. Ibrance was the first of the 3 CDK inhibitors that I talked about. It was approved by the FDA, so it has quite a bit of follow-up. And the results have shown that women who were on Ibrance and aromatase inhibitor had more than doubling of the time that they could be on the medication before cancer growth compared to aromatase inhibitor alone. So to say it more simply, if you're in the aromatase inhibitor by itself, within about a year, about half of the women will have cancer growth and need to change treatment. But if you're in that combination, the average was about 2 years before there's a need to change treatment. One of the questions, I'm not sure if that's what the potential question is about, but in our conference last month, there was more discussion of whether people live longer if they received Ibrance versus not. And there's some combination of groups from the few of the Paloma trial suggesting that it does provide this additional benefit, but it's been shown a little bit more definitively in the last few months with the Kisqali and Verzenio. Our thoughts is that all three CDK inhibitors are very, very beneficial and should be considered as first line and beyond for women with hormone receptor positive metastatic breast cancer.
I have a couple follow-up questions, if I how do women like myself learn about or take part in clinical trials?
So finding a clinical trial could be challenging. There's a lot of information out there, but it may not always be very accurate. So I would definitely start by talking to your doctor or clinical team about what clinical trials do you have or know about that available to me. Second, you can look through some search mechanisms. The most common one is clinicaltrials.gov that lists, and you can narrow, you can do an advanced search, you can put a mileage that you'll be willing to travel for example, or you can put particular cities where you might have relatives or friends you could stay with and you might want to travel and consider studies, and then put the stage of the cancer and some other characteristics. But it could be overwhelming. So if your clinical team can help you, that would be my first choice. I usually ask the women I take care of whether there are particular cities they could travel to if they needed to. Of course, looking at our larger geographical area is easy, and we'll have connection with the main breast cancer providers, for example, in the DC or other Maryland or even Pennsylvania sites. But I admit it can be challenging. There's some apps that I think will be helpful to us in the near future.
Okay, I have another question.
Sure.
So we're learning more and more how important gut health is particularly for our immune system. And there's not a lot, it seems there's a lot of conflicting information out there about the importance of diet. But one thing that we can all agree on is that what you eat is important, right? From everything from, spikes in glucose levels to your, inflammation and so forth. Can you speak to the importance of diet and how women in our audience can find information, or who do they speak to, or can you make any recommendations?
Yeah, so you're absolutely right that diet is very important. We do know that some diets are more we call pro-inflammatory and some may help reduce inflammation. So I usually start by just really talking to them about what their usual diet looks like, and start with small steps to reduce potential inflammation. You want to have a balanced diet. So what you're told is good for your heart is also good to try to keep cancer in check. Good proteins or chicken, fish, not a lot of red meat, fruit, vegetables, so plant-based. I encourage people, and we try to give them tools to cook and have very, very little processed food if possible. The number of calories and no high sugary. I don't tell people to avoid sugar, but avoid sodas and in many desserts. We want people to stay healthy, but to also eat well. I do find in most dietitians in cancer centers are focused more on helping people who are not able to eat and supplement and nutrition, as opposed to helping with the small dietary changes that are sometimes needed. So we try to create resource sheets to nutritionists or dietitians that can help people with their queries. We also know that maintaining a reasonable weight and regular physical activity help reduce inflammation and keep people healthier with their cancer.
Great. Are there any more, any other questions from our audience at this time? No? Okay. Well, Dr. Stearns, this has been a pleasure. Thank you for all of the updates. It's always, I think, I really feel strongly that knowledge is power, and receiving information is always helpful. So I really appreciate your yearly updates. So thank you so much. And thank you everyone for attending. I will post this recording on our YouTube channel so you can rewatch it and download it there. Okay.
Thank you so much.
Bye, everyone.
Have a good afternoon.